Yeah, she's here. People. So good afternoon, and welcome back from lunch. My name is Amam Mbakwem. I'll be the moderator for this session, and I'm also the vice president of the World Heart Federation. So this afternoon, we'll be addressing the burden of neglected childhood onset heart diseases. And I have a number of distinguished panelists, who will do justice to the topic. And the objective actually is for us to raise awareness, highlight the global burden of neglected childhood onset heart disease and need for policy action, advocate for WHA resolution. So we're going to discuss the significance of WHA resolution for pediatric and congenital heart diseases to mobilize global action. We're also going to share best practices and strategies for effective advocacy to influence policy change. And we'll also explore the role of partnerships between governments, intergovernmental international organizations, NGOs, healthcare providers, and patient organizations. So we'll cover, scope of things from congenital heart disease to rheumatic heart disease. Then we'll do a deep dive into antenatal care, and then social, environmental, and commercial determinants of health. So to start us off, I'll introduce the keynote speaker, who doesn't need much introduction for those of us who are working in the congenital field of pediatric cardiology. He's Professor Krishna Kumar. He's a globally renowned pediatric cardiologist and a leading advocate for equity in cardiac care for children. He chairs the World Heart Federation on Neglected Cardiac Diseases expert group, where he drives global efforts to prioritize congenital and rheumatic heart diseases. His leadership has catalyzed scalable, cost-effective models of pediatric cardiac care in resource-limited settings. Professor Krishna, can you please come up? So a few of the panelists will be joining us virtually. Some of them may not be able to make the meeting. They are in high-level negotiation meetings at the WHO. But I'll bring up all the other panelists who are physically present to please come up and sit here. I'd like to bring up Ms.Tanya. She's the founder and CEO of Heart for Heart, an Australian patient organization supporting, educating, and advocating for people living with heart disease. Drawing from personal experience with heart health challenges, she champions awareness and equitable access to care, especially for individuals with congenital heart disease. Her work brings the patient voice to national and international platforms, strengthening the call for policy change and community-based support. Tanya currently serves on the board of the World Heart Federation. You're welcome. My next panelist is Professor Andrea Beaton. He's a pediatric cardiologist and global health leader based in Cincinnati Children's Hospital. She has led large-scale research and implementation efforts to improve the diagnosis and management of rheumatic heart disease among children in resource-limited settings. Her work exemplifies how early intervention and community-based care can transform outcome for children with preventable heart conditions. Two of our panelists will be joining us virtually, Professor Olga Mocumbi. She's a cardiologist and professor at Universidade, Eduardo, Mondlane. Renowned for her research on neglected cardiovascular diseases, she focuses particularly on rheumatic heart disease and cardiomyopathies affecting children and young women. Her clinical and policy expertise has been instrumental in shaping global advocacy efforts for early diagnosis, prevention, and care of childhood onset heart conditions in low-resource settings. Anna currently serves as co-chair of the WHF Science Committee. And Dr. David Watson would also be joining us virtually. Dr. David Watson is a physician scientist and health policy expert at the University of Washington. His work focuses on health system transformation and modeling evidence-based policy solutions to address non-communicable diseases, especially in low and middle-income countries. He has led research on the global burden and economic impact of rheumatic heart disease, providing critical evidence to guide investment and policy prioritization. Please, I hope the virtual panelists are online. Hi, Anna, how are you? Can you hear us? Hi, okay. The last panelist is in the room.
Hi, I can hear you well.
Okay. Ms. Zaskia McNab. I hope I'm pronouncing it right. Okay. She's a Namibian diplomat who serves as first secretary at the permanent mission of the Republic of Namibia to the United Nations in Geneva. With a background in political and economic affairs, she has represented Namibia in key multilateral forums focused on global health, trade, and disarmament. She contributes to Namibia's long-standing commitment to equitable health access. In particular, Namibia was the first co-sponsor of the resolution of WHA 71.14 on rheumatic fever and rheumatic heart disease adopted in 2018. You're welcome. So at this point, I'll call up Professor Krishna, who will do the pace setter lectures, and we'll take it from there. Thank you.
Thank you, Amam, and thank you all for coming to this, what perhaps is an important area of focus for the World Heart Federation. We've chosen neglected heart disease for the lack of a better term, and we're talking about those who neglected heart disease that start in childhood, and actually it covers most of them. We've sort of tried to use some kind of a definition for neglected heart disease, but we're still in the midst. It's work in progress, but essentially it's conditions that are under-recognized, overlooked, despite a very substantial global burden. And interestingly enough, they affect the most vulnerable populations, which are the youngest, the poorest, and marginalized. So in this category, we have rheumatic heart disease, and we collectively felt that congenital heart disease also belongs in this category, and you will probably agree at the end of my talk that it's very much within this category of neglected heart disease. Chagas disease definitely is iconic example of neglected heart disease. There are certain forms of cardiomyopathy and endomyocardial fibrosis, Takayasu arthritis. These are relatively less common, but they are also worthy of substantial global attention. And there are a host of infections that really belong to the category of neglected heart disease. What they need is targeted, sustained, and forceful advocacy. And that's why World Heart Federation is a very important ally in their global control, or global, for them to be addressed globally. So this session, we are trying to raise awareness and highlight the global burden of disease, advocate for a WHA resolution. We do have one for rheumatic heart disease, but we'll be trying to do that for congenital heart diseases as well. And then share some of the best practice strategies for effective advocacy to influence policy changes, and look at ways in which we can partner with each other, with governments, with international organizations, and find a way that we actually generate a substantial collaborative effort. So in my presentation, I would look at the burden of childhood onset disease. I would focus substantially on rheumatic heart disease and congenital heart disease, its distribution, the global trends and challenges, what policy frameworks and resolutions are really in place, and some successful models that have been used, especially for congenital heart disease, and then what are the gaps in translation, and are there any pragmatic strategies we can come up with. So with rheumatic heart disease, we all know that the burden has this very pyramidal sort of situation where we have a substantial subclinical burden that is completely significantly under-recognized. And then it tapers down to more manifest forms of rheumatic heart disease, which really impact a lot of lives. So this is a picture, this is old relatively, from the global burden of disease, which was presented in Nature Reviews, but I've been told that there's going to be a new update on the global burden of rheumatic heart disease coming out very shortly in a few months. So we will have an update on that, and it's going to be interesting to see what has changed. And these are numbers that are typically quoted: 39 million people living with the disease, and nearly 300,000 deaths, and more than deaths, it's a huge amount of DALYs that are lost. The global trends, we have again relatively old data. Prevalence data is more or less the same, and you may say it's sort of a little higher because many patients are living with the disease. And then in terms of deaths, there is a decline, but that declining trend will be more obvious when we look at the more current global burden of disease data. The problem really is understanding rheumatic heart disease in younger populations, because it's a slightly different than from the older populations, in the fact that it's very difficult to handle, difficult to manage, and there are certain forms of valve afflictions in the young that are quite unique, and they're pretty much prevalent in the most endemic and the most affected regions of the world. You don't see juvenile mitral stenosis once the disease declines, the burden declines. I've grown up seeing the way rheumatic heart disease has changed in young patients. So when I was a cardiology trainee, our wards used to be full of rheumatic fever. We would see 12-year-olds with rheumatic mitral stenosis, a 14-year-old who needed a balloon mitral valvotomy. That just disappeared. And you have some very impressive pathology that you see. I've created some of these images with 3D echo. You have this intense subvalvular deformity that tends to happen in this, suggesting a very aggressive rheumatic process. And they are very difficult to manage. And they have disproportionate pulmonary hypertension. They're really hard to treat. And as a result, of course, even rheumatic mitral regurgitations, it's actually very difficult to repair many of these valves. Is a good example of a case that I recently took care of. And it tends to be very much limited to the most marginalized population. You don't see advanced rheumatic valve heart disease in children in regions where the disease has become less prevalent. It's sort of almost always limited to high prevalence regions. And we don't fully understand how that happens, but presumably because of a very aggressive process with frequent recurrences, both overt and covert forms of recurrences. And then managing them is extremely difficult. You can't repair them so easily, and you replace them, you end up putting in a very small valve. You can't, and then the issue of anticoagulation and whole lot of problems that the children with rheumatic heart disease suffer from, and it's very difficult to manage. About congenital heart disease, truly, until very recently, the burden has been unrecognized. There are numbers that not very far away from what you see with rheumatic heart disease. And the dynamics are very interesting. The changes that have happened with the global burden of congenital heart disease is different from how what's been happening with rheumatic heart disease. So these are numbers that we come up with. Again, a substantial loss of lives and a substantial disability that results from it. But this tends to afflict populations early in life. So 70% of the deaths are in infancy. So that's why it's severely under-recognized. But what's really not known, despite this very important study that was published by the Global Burden of Disease Group, and this slide is to be given to me by Megan, by actually Craig Sable, who shared it, and then Megan was working with Craig at that time, and they found some very important statistics that most of the community, both amongst pediatricians and cardiologists, they're not aware of this. which is that congenital heart disease is amongst the leading causes of infant death across the globe, especially in middle and the middle socio-demographic index regions of the world. And it's currently ranking number 2 in many parts of the world that have actually had substantial reductions in infant mortality from preventable causes. So where I come from in Kerala, it's the leading cause. And many parts of the world, like many parts, large areas in China and the developed parts of India, entire Southeast Asia. So as the demographic transition is happening and there's a demographic shift in childhood diseases, there is a real change that has been happening with congenital heart disease. It's getting more and more important. So this is because the real decline has occurred with the preventable causes. So this picture is given to me by Bistra, and this is a slide you see very often these days. It's because it's happening everywhere. As the burden from under 5 mortality rate from all other causes is declining, children with heart disease, the rate is sort of constant. So this is unmasking the burden of congenital heart disease. And I've sort of witnessed it right in front of my eyes over the 25 years that I've worked in the state of Kerala, where rheumatic heart disease just disappeared. Childhood infant mortality has come down to a small number comparable to many parts of Europe. But so congenital heart disease really started to become extremely important. But access to care is really very poor. And the most important thing that matters in congenital heart disease is the fact that you have to prevent them from dying early. So you need infant and newborn heart surgery. And that's severely lacking in most of the world, low and middle income countries in particular. So the numbers are really disturbing. So if you look at almost all of Africa, the access to infant heart surgery is 0 to 5%. 95%, 99% of babies are dying without any care, without diagnosis. When you look at, so this is the essential part of the world, and this map is represented in such a way that it grows in size in proportion to the population, number of kids living there. And when you look at this map, for most of the world, there is very little in form of infant and newborn surgery. And so most babies in this region, they're dying. And there's a really substantial difference between the low and middle income countries and the high income countries, and the differences are stark. So what determines access to pediatric cardiac care? And it's an interesting thought, because we tend to be limited to, most professionals, cardiologists who practice advanced care are largely insular. They live in big hospitals in ivory towers, and their whole perspective is limited to what they can do for the patients who get to them. But what determines access really starts much earlier. It starts with recognition. And there's tremendous lack of awareness in the pediatricians community in places where heart disease is not identified. So it just doesn't exist in their consciousness. So there's no prenatal or newborn screening in those areas. In most of the world, there isn't. So then it comes to the next stage of making a diagnosis, confirming it with echocardiography. There's very little expertise in the community or at district hospital levels in secondary care settings. Referral pathways don't exist. There is no system for stabilization and transport. Newborn transport is not a phenomenon, doesn't exist for most of the world. So as a result, you have a tremendous amount of attrition that happens before babies can get to tertiary heart centers. But then the number of centers that exist is also very inadequate. So essentially, what policy frameworks are in place for rheumatic heart disease and others? We just have to look at what is existing. So what are we going to advocate for? For rheumatic heart disease, this is what was done at the 2018 Global Resolution, and this was what was submitted to the World Health Assembly, and this is what was agreed upon, what was asked from the member states. But essentially, I'm going to have a I've highlighted the bottom line, which is the report on implementation of this resolution will be discussed in the 74th World Assembly. So when I looked at all what was written about the 74th World Health Assembly, I couldn't find anything on rheumatic heart disease. I thought the whole agenda was hijacked by COVID, but probably it was more complicated than that. And at the end of the day, essentially, none of this has translated into any meaningful action. And we just have to acknowledge this as a serious failing and reflect on what happens to policy. We still, nonetheless, are trying to put a step forward for congenital heart care. And it's the global coalition of pediatric and congenital heart disease. That's the global arch coming together with an NGO like Children's Heart Link and trying to make a serious case for a better future for children with congenital heart disease. The facts are disturbing. There's a very high burden of congenital heart disease. There's very little care that's available for them. You combine that with rheumatic heart disease, childhood heart disease is a serious problem that's terribly neglected, that's not given adequate attention. So everybody else, all governments, all need to take action. That's what we are asking them to do, and we are trying to tell them that, listen, you need to integrate these conditions into universal health packages and find a way to actually help these children. And it's not it's not something that is a pipe dream. It's actually happened. If you look at some models of CHT care, and I'm going to share a few of them, it can be done. It sounds extremely difficult, but it can be done. And I'm going to share a few models. One model was developed within the state of Kerala, and I was fortunate to be a part of it. This is the gentleman who really was the reason why it happened. And he's a public health government representative who really took it upon himself to make a difference. And he, together with some of us, looked at addressing the entire care continuum and making a difference to the extent that every single baby got picked up and referred in the state of Kerala. A big system was laid out. It's a very interesting story. It's there in this publication. But essentially, a whole system of looking and identifying heart disease through newborn screening, then finding a way to engage all the experts in the region, both within and outside the government sector through public-private partnerships, creating a web-based registry to make sure that everybody can register their patients, and then you can track them in real time, and then finally making sure that they all receive care, and that care is funded by the government. So this really made a difference. We were able to reduce all-cause deaths, the congenital heart-related deaths, by 41%, and even more so in the more recent data iterations. And the infant mortality of Kerala, which was sort of stuck at 10 for many years, 10 to 12, suddenly came down to 6 and by 2020. So we achieved single-digit infant mortality. We can't claim all of it was because of congenital heart diseases, but something did happen. So this was a very good example. Another very remarkable example is my former fellow, Diminda Samarasinghe from Sri Lanka, who took upon himself to really galvanize the government into making sure that every child had access to congenital heart surgery, and really made a big difference to the whole country through extensive advocacy and engagement of a whole bunch of stakeholders, after which they were able to raise the funds and make a difference tremendously to the care of children with congenital heart disease for almost every child in the island. So this was a remarkable effort which has tremendous collateral benefits, incidentally, in terms of affecting, improving the lives of many other childhood diseases, because of just improvement in the continuum of care takes along with it children with respiratory illnesses, with other conditions, with other newborn conditions as well. And really a tremendous difference happened in this particular situation. So I'm going to finally end with the challenges we have in translating policy into action. And I'll just share my thoughts. Many of these are very personal. And I think fundamental challenges exist in large settings. When the burden is very large, it's overwhelming. And so no one knows where to start. When it's diverse, like in India, especially when you try to talk about rheumatic heart disease control in a country like India, where the burden could be very little in certain parts of the country or very high in certain other parts of the country. Poor governance, which basically reflects by two things, a disconnect between policymakers and ground realities. I think this is the essence, the crux of where we have to deal with, where as an organization like World Heart Federation, we can make policies, we can advocate, but much of that has to actually translate into ground realities, and they are very challenging. Mostly it results from disorganized health systems, chaotic, fragmented, and multiple healthcare providers, each with their own vested interests. So it's very difficult. Apathy is a huge problem. If you take the average cardiologists in India and perhaps in other countries, there's just very little in terms of what they understand about, they just don't look at their specialty through a public health lens. They just look at the patient who comes to them. And it's a completely different kind of engagement that happens. And there is no leadership, really. When it comes to these things, you need tremendous committed leaderships at every level, at a community level, at state level, at regional levels. And there isn't a system to nurture, develop these leaders. So this is perhaps the reason why we just don't do a lot of all that. And I think even just looking at us as professionals, we need to look at, I think, a very fundamental aspect. So for example, in rheumatic heart disease, tertiary healthcare professionals are going to be dictated where the schools are, where there is access to care, where the urban settings are. They're going to live there. And they will be only able to take care of the most affluent. So the rural poor and marginalized populations don't get access. So how do we get diverse stakeholders motivated enough to act in unison? So this is a very fundamental problem globally. So the thing, as I see it, it's about aligning individual aspiration with societal priorities. And I think the best healthcare systems is when you have a perfect alignment of these three specific issues, which is what stimulates us intellectually, what brings our salaries, what the society needs. And the best health systems is when you have the best possible alignment. Thank you.
So thank you, Professor Kumar. I'm just wondering, with the statistics that you've reeled out, why are we still wearing blindfolds? It's as if, that's why we're calling it neglected, because nobody's talking about it. And then, I could identify with what you were saying. For me, from where I work, the very severe congenital heart diseases will die in infancy. And then the less severe ones will pick them up like in pregnancy. And that becomes a lot more complicated because we have to deal with the fetus, we have to deal with the mother. And then the cost of managing them at that time, it's multiples of what we would have done, if we handled them as babies. So why are we still wearing blindfolds, both from us healthcare givers and policymakers?
Can I understand what you said? Why are we
wearing blindfolds? Why are we, because it's neglected, because we are not thinking about it, we're not doing anything about it. So as far as I'm concerned, we're wearing blindfolds.
We all do wear blindfolds, and some of us are more willing to take them off. But one way you can survive in these very difficult settings is to deny the problem or pretend it doesn't exist. Yeah. So then you can keep your sanity in some ways, or you can, not get too depressed. So this is a feature that we see everywhere. And it's not to make people feel guilty about not doing, I think the whole way we need to approach is to really find an organic way of getting people to understand and look at their specialties through a public health lens. It's a fundamental fault with our medical education, the way we are groomed. We've become so specialized and invested in technology, in high-end medicine, in taking care of the individual patient, we completely neglect the collective problem. And it's a very fundamental issue. I know that it cannot be easily addressed in this forum, but we can actually start to make some changes in the way people think about diseases.
Thank you. Thank you. I hope we will start removing the blindfolds by the time we are done. So, Ms.Tanya, I'll come to you now. As an advocate with lived experience and founder of Heart for Heart, how has sharing your experience and expertise helped shape narratives or influence decision makers around congenital heart diseases?
So I was born with congenital heart disease, and it was through my experience that I founded Hearts for Heart. I looked for information, support, had issues with barriers to access, and so and I wanted to connect with other patients who were going through a similar or same condition as me. I didn't know what my future looked like, and I was incredibly unwell, and so that absolutely shaped and still shapes how we operate today. And although now it's not just myself, it's the community that I represent, and so essentially we're their voice. But for patients who have heart disease, it's a lifelong journey, and it's complex, and our system is fragmented, and so we're constantly changing and evolving, and with new governments that come in, they look at cutting funding, and so but I certainly find that with the work that we do, we're very much a driver of advocacy. So we know the clinical societies are very busy, and clinicians, and so we keep them informed in terms of what's happening in health policy and where we need their support, and so it's certainly a collaboration. But healthcare is changing all the time, and so we just need to be sure that the patient voice is included in the delivery of healthcare, because we're the only ones that truly understand the complexities from diagnosis through to treatment, ongoing management, and so forth.
That's very interesting, because some of where we practice, there's a bit of stigma if you have congenital heart disease, so you don't want to be open about it. So it would be difficult to form such a group, that would push for policy change. I wonder how we're going to get past that.
It's a good question, and because, I think we've just embarked on a patient advocacy training academy, and I think it's very much about timing. I think if the patient is unwell, then they're not in a position where they're able to use their voice or want to give back. But at different times of their journey, then they absolutely, not all patients, but certainly some patients want to get involved, because they want to sort of turn a somewhat obviously negative experience into a positive one, and they also want to get involved and have the opportunity to make change.
Thank you. Ms. McNab, I come to you now. And Namibia has demonstrated strong leadership on the global stage, including as a co-sponsor of the World Health Assembly resolution on rheumatic fever and rheumatic heart disease. What motivated your country's engagement? What impact have you observed since its adoption?
Thank you very much. Namibia, we are classified as an upper middle income country, but that does not really reflect the situation on the ground. So what we have experienced in Namibia is that 90% of the burden of congenital heart disease patients is still carried by the state. And like you said, there's still a stigma and cultural beliefs and everything around these kinds of diseases. So it was very important for us to also bring that to the forefront and make sure that not just that rheumatic heart diseases comes to the forefront, and that it becomes a discussion in the assembly to bring attention to it and to assist countries that with capacity building and trying to solve these kind of problems. So for us, we try to continue working on bringing attention to it. We've got a cardiologist, Dr. Feni, that is very passionate about this topic. It's unfortunate that she could not be here today. So we try also to bring light to the situation, specifically in Namibia. And because our situation is Like I said, we are classified as the upper middle income country, but it does not necessarily reflect the situation of the Namibians on the ground. And we have seen that also we are very, a country that's impacted, highly impacted by climate change, which also contributes to these kind of diseases. So we want to highlight this and also get the necessary support for the patients, but also for the country. So that is why we continue, even through the diplomatic missions, we continue trying to highlight this through the World Health Assembly, through our partners, and continue doing the work and supporting the cardiologists at home.
So do you think you've had any effect on the other South African countries? The Southern African countries, I mean, some kind of pull-in effect, you know? I'm just wondering, maybe not?
That one I cannot specifically give you an answer on, because that one, it will be maybe the cardiologist that can give an exact estimate of that. But at the moment, we have a limit we have a limitation with even the cardiologist or trained cardiologist at home, and even nurses for the aftercare. So we, like I said, this burden is carried mostly by the state, because it's also so expensive that private care does not want to take on that burden.
Yeah. Thank you. So, Professor Beaton, how can cardiac care be more effectively integrated into primary health systems, especially in countries where specialized services are limited? I know you have a lot of experience working in low-resource settings.
Yeah, thank you. I think that's a really complicated question, but there's some commonalities between how we can approach integration of these specialized services into low-resource health systems. I think a few points here. The first is that there's a huge, as KK pointed out in his talk, there's a huge knowledge to action gap for pediatric and congenital heart disease and rheumatic heart disease as well. We know a lot about how to, at least for rheumatic heart disease, how to prevent disease, how to find disease early, and how to keep patients safe when we found out they have disease. But we lack the implementation strategies, the packages of services to give to governments to say, okay, we have these evidence-based interventions, and this is how you get them to your population. And I think that's one of the challenges we've had with the 2018 resolution. First, we didn't have any guidelines. WHO hadn't published guidelines in a really long time, so governments didn't have those guidelines to look to. That's been remedied this year with the publication of RHD guidelines from the World Health Organization. And the second is we didn't have implementation strategies that were proven. And so governments really struggled with knowing how to get these interventions to their populations. And that's the space we've been working in, is how do we work with patients and with communities and with health systems to develop really pragmatic implementation plans. How will we get these basic core services out? And in particular for primary health care, in Uganda right now, we've got a really close collaboration with the Ministry of Health, where we're trying to develop a base package of interventions that can be deployed anywhere in the country. And we've chosen to focus on two strategies there for rheumatic heart disease. One is echo screening. We know 2% of the population is living with undiagnosed rheumatic heart disease. We know if we wait for them to come to clinical attention, the mortality is just horrific, but we can find them early. And so we're working on task shifting models. How do we teach primary care nurses to do that screening, single view, 1-minute studies to look for disease? And how do we then provide registry-based prophylaxis to keep those patients safe? And it's only one example, but we've been running a program in Uganda for the last 18 months, or the Ministry of Health has, with us as implementing partners, the Uganda Heart Institute and our research teams. And in that time, in one district, a remote district in the north of Uganda, we've trained 60 primary healthcare nurses to screen for rheumatic heart disease. They've integrated point-of-care echo into their clinical work, in their workflows, also in their community outreaches. They take that echo with them when they go for vaccination campaigns and other community outreaches. And in only 18 months, as part of their normal work, they've screened 25,000 community members for rheumatic heart disease and have made almost 400 new diagnoses in a single district where almost no one had a diagnosis before the program started. I think these types of models are what we need. We need to keep working with communities to develop these, and we need to do it in a really rigorous way that we come out with an adaptation toolkit so that other places can pick up these kinds of strategies and have a package of services that they can pick up and bring to new locations. Just one example, but
yeah, that's very interesting. I'm impressed that the Ugandan government is working with you. I represented the president in one of the African, World Heart Assembly meetings, and I was supposed to make a statement, and my statement was on rheumatic, fever and rheumatic heart disease. And the way that we are talking, I was wondering, are we on the same planet? And I said to them, one shot of benzoyl penicillin at the right time can prevent all this. But, the interesting thing was what one of my country policy, the entourage said to me after the meeting, oh, you're so passionate about this, your rheumatic heart disease. So it's not on their table, it's not on the agenda, at the meeting, everybody was talking, reeling out all the good numbers, all the things they were doing, the universal health care. And I sat there and I was wondering, is it the same country I live in? Or is it somewhere else? Well, thank you. So I think we'll take on Anna, are you still there? Hello, Anna.
Yes, I am.
Okay. I have a question for you. I know you've done a lot of work on rheumatic heart disease, particularly among young women. So how do you see the role of antenatal and maternal health services in reducing the burden of childhood onset heart diseases?
Thank you. It was very interesting to hear, KK. Thank you very much for your summary of where we are, and to hear all the other panelists. My contribution in this point would be that there are a lot of challenges in our antenatal care clinics and maternal health services, but there are also opportunities. And the biggest opportunity for me is the fact that maternal health services are linked to child services in our countries. WHO's programs link these two areas, and I think that we have been missing opportunities for increased detection during pregnancy and postpartum, for that matter. We have been missing opportunities for counseling and education of women. And also, I think that we need to potentially invest on easier pathways for risk stratification and differentiated models for women of reproductive age. Rheumatic heart disease in countries such as Mozambique is the primary cause of indirect mortality after hypertension. After hypertension, we find a lot of women that have undetected rheumatic heart valve disease. And unfortunately, the outcomes are many times very poor and even deaths. So I think that this is something that needs to be taken seriously, and I strongly recommend us to consider these aspects that can be incorporated and can be integrated to antenatal and maternal health services.
Thank you so much. Dr. David, are you still with us? He's joining us virtually.
I am. Hello.
Oh, okay, thank you. So I have a question for you. We know you've worked extensively on the economics of rheumatic heart disease. What does the evidence indicate regarding cost effectiveness of primary and secondary prevention, as well as early diagnosis, especially in low resource settings?
Yeah, thanks. It's a very important question. So for rheumatic heart disease in particular, we do have a small literature that talks about relative prioritization of different types of interventions. And what we know pretty well now through several studies in different settings is that both primary and secondary prevention are cost effective, and within most countries, sort of like thresholds for cost effectiveness for patients who are seeking care. The core technologies we're talking about here, benzathine, penicillin, and whatnot, a few minutes of a nurse's time are effective and fairly cheap. And we've shown this, several times. The real challenge is getting those out to people who aren't seeking care. So if you just look at the patients who are, showing up to clinic right now, it's a pretty effective strategy. But the problem is most people aren't seeking care. And what we don't know is how do you find cost-effective strategies to improve utilization of services? There was a paper from 2021 that was supported by World Heart Federation, an investment case for rheumatic heart disease in the African Union region. And in that paper, essentially primary prevention shows up as something that doesn't look very cost-effective when you have to go spend a lot of money trying to build a primary healthcare system to treat sore throats. Of course, with secondary prevention, you've got to think about how you develop sustainable and fundable models of, expanding access to echo screening. And so these are the real issues, right? Is how do you build out the healthcare system in a way that's lean and cost efficient? And so this is where I think we still need to develop some evidence. And as Dr. Beaton was saying, what is the sort of cost of all that support system, the implementation strategies needed to actually get these interventions out in the real world? So I would say that there's a lot of strong evidence in general that these interventions, these preventive interventions provide good value for money. But what we need to do is to find ways of getting them out to the populations who are not currently accessing care, and to do so in a way that is mindful of the fact that these programs would be competing for resources with a lot of other disease programs.
So thank you for that. But how do you think we can use all that evidence, to leverage our communication with policymakers, to get them to fund and to look after, these early childhood diseases?
Yeah, I think what I would say is that economic evidence is a piece of the puzzle, but it's only a piece. We saw through a bunch of adult NCD investment cases over the past decade that really focused on return on investment figures. They were aimed at trying to get more investment in NCDs in general. And we saw that the success of those attempts was fairly uneven. Some ministries are convinced, others are not. And in conversations that I've had informally with people in ministries of finance, there is a need to actually kind of take this back to a human case. A lot of people assume that these interventions that you're advocating for are pretty cost effective. And so the question is, why do we do this rather than some other health intervention? Again, because there are very limited resources for health systems overall. So what makes this particular condition special compared to all the other great things that advocates are coming up and, saying should be funded? The other thing that's really, really important, and this comes from people who work in ministries of finance and develop budgets with ministries of health, is the need to actually translate this economic evidence and your sort of advocacy into showing results. So many people in ministries of finance assume poor implementation in the health sector and a lot of waste of money. And this is a broader problem within ministries of health around public financial management and other issues. But basically, in as much as you can show that you can generate results and make good use of Ministry of Finance money, you're going to get more traction. And so I think building trust between ministries of health and ministries of finance is the biggest thing, and advocating strongly that these conditions have a human toll and an equity toll that's especially important is quite important. I think cost effectiveness is one piece of that, but I think there's this broader agenda for showing why childhood onset heart disease is so special, and that we can actually do programs in the real world, deliver results, and make good use of resources. Those are the big missing pieces.
Thank you. Ms.Tanya, I'll come back to you. I know you touched a bit on it when you were, giving your response to my first question. But in your advocacy work, how do you approach collaboration with government, clinicians, and international organizations to ensure that the patient voice is not only heard, meaningfully reflected in policies and programs?
I position patients as equal stakeholders. We've got, at some point, most of you in this room made the decision to, become a healthcare professional, whereas we didn't quite have that choice. But again, through our journey, we know, as I mentioned before, the complexities from diagnosis through to treatment to the management and so forth. So it's really important as well that we're included in the co-design of research, clinical guidelines, the delivery of healthcare, because if without the patient being included in those discussions, then that's where I think there's been the missing link of truly understanding why patients aren't adherent to medication, and all of the holistic patient journey, right? So, and so I think, but we can't approach government in isolation. We need, we need all of the stakeholders, researchers, clinical societies, even industry when needed. And I really sort of agreed with what the gentleman was just saying, that when you're advocating, you need to have a good solid strategy. And you need all of the links. So you need to be able to show that you're saving the government money, but that there's the prevalence, and then there's the clinical need. But you need to bring it to life with the patient story, and that's what politicians connect to. And this is where I suppose the role of the patient organisation. I've taken in the clinical societies, and I've translated the benefits into layman's terms, because that's what they're going to understand, but that's also what they're going to connect to as well, the humans at the end of the day.
Okay, so you think the patient's voice is one of the most effective strategies to get them to listen?
Absolutely. A clinician came to me, said, right at the beginning, said, we've been advocating for this for 10 years, industry have been advocating for 10 years, we've got nowhere. I started engaging with them, and the clinician started laughing. He said they'd fall asleep when we'd meet with them. And the moment you started talking, I spoke a little bit about prevalence, a little bit about, what it was. And by the way, I had this procedure, and, went from not being able to work to getting up and walking around that evening, and they woke up. And, and that was a very small example, but absolutely, you have to bring it to life. You have to give them, this is how it's going to benefit the community. And so the patient voice is really essential in this, the patient story. But it's teaching people and patients how to share their story in an effective way, as well as a big part of the piece.
Thank you. So I'll come back to you. You're a diplomat, advocating for equitable health policies. What do you see as the most effective way to elevate childhood onset heart diseases on the international agenda?
Yeah, thank you. So yes, the role of for us as diplomats is, we are not the experts, but I believe that we all play an important role to get the message across and to also advocate for the patients. So we have to use, as diplomats, we have to use the platforms that we have through the World Health Organization, global funds, the other NGOs and international organizations, and even our bilateral partners to bring the message across, especially from your country perspective. You bring the message across and you try and garner as much support and collaboration as possible, because we want to, also as Africans, we want to move away from aid assistance. We want to be self-reliant. So we want to build infrastructure, whether it's capacity building, whether it's actual infrastructure. We want to build this with equal partnership in order to become self-reliant and be able to give the care that our people need. So it is important to spread the message and try and build those collaborative partnerships, because some countries are very well advanced in some of these areas of diseases, and so it is very important to build those partnerships, but it should be equal partnerships where tomorrow we will be able to stand on our own 2 feet and move forward. So I think it's important for the diplomats also to bring that message across and build that.
Okay. I want to piggyback on Tanya's response. You're a diplomat, so as far as I'm concerned, you're a policymaker. You're part of government. So what would you want to hear from me when I'm sitting in front of you?
No, it is definitely important to hear the patient perspective, because policymakers can also be, but policymakers are also influenced by the voice and the message from the population. Okay. So it is important for everybody to be part of that chain, because it's only the government or the policymaker may think that he's doing something right, or that we are providing adequate service and adequate care, but it's not what the patient is experiencing. So in order to bring about that change, it is important to have the patient involved in order to better where we are going wrong and provide better service. But also just to bring, to highlight the journey that the patient goes through, the stigma, the cultural indifferences, being able to get to the point from being a patient to becoming a productive member of society. So it changed so that it can completely change the narrative for the lawmakers as well.
Thank you. So, Keke, I'm coming back to you. You shared such a beautiful story in Kerala about the congenital disease pathway. Was it you or was it the policymakers? Where did the conversation start?
So we had a fortunate alignment, fortunate coming together of quite a few things. One, the state that was ready for this. A champion who was willing to really go all the way to try and push this, a public health worker. A very open-minded minister of health and a very driven health secretary with astute administrative skills. So this sort of fortuitous alignment of forces is what made things happen.
Yeah.
Of course, when you build something, on these kind of arrangements, it tends to be a fragile arrangement because you're dependent on lots of good things coming together, and sometimes that may not always stay that way. But if sufficient momentum is generated, then it's very hard to dismantle what's been put together.
Sure.
So we have to, if it happens fortuitously, it's great. If it doesn't, then we have to make it happen. We have to find people who are willing listeners, who get motivated through this process. For this to happen in Kerala, it was 10 years of advocacy for us before people started to listen.
Interesting. And what motivated you to stay on for 4 years, talking about the same issues to people who don't want to listen?
Just seeing the fact that the potential for, making a difference.
Sure.
And then you don't actually, when you do have small successes in that whole 10-year journey of advocacy, you have small successes. You can, for example, transform the pediatrician community to making them realize, oh, indeed, congenital heart disease is important. You can share success stories of individual patients doing remarkably well. So, in that journey, you have these little successes that motivate you and that give you hope. So it's not as if it's like a constant uphill climb. You do have breaks in between where you think, okay, there's hope out there. So that's how it starts. And, so these things happen in a very complex way. We tend to give credit to a few people, but it's really, when the time is right, changes happen. You need these catalysts to make them happen. And I think that's going to be the role of the World Heart Federation, to serve as that kind of a catalyst in others' endeavors to really make it happen.
And I think we as healthcare providers need to be sensitive to pick up those opportunities when they arise, and use them effectively.
Correct.
Okay. So, Professor Beaton, I'm coming back to you. Your initiative has initiatives have highlighted the impact of community-based screening and early diagnosis of rheumatic fever. What lessons can be applied or adapted to support a broader implementation? I know it's worked in Uganda. Do you think it's going to work in all the other African countries, or are there unique, situations, unique issues in Uganda that made it happen successfully?
Yeah, thank you. Again, I think these questions are tricky, but Uganda is a special place. There's no doubt about that. There's a huge groundswell of interest in rheumatic heart disease there. There's a well-functioning heart institute, a tertiary center that has research and clinical capacity to care for heart disease that's not present across many of its neighboring countries. And there's real Ministry of Health engagement. I think the question is how we got there. How did the country get to that place where they could be a leader in rheumatic heart disease sort of implementation strategies? And I think, like KK's story, that's a long decade of work and collaboration and partnership from the patient level. And we have a lot of patient organizations there all the way through the ministry. And it was building clinical capacity and research at the same time in a place that both allowed the Uganda Heart Institute to retain their faculty. There's been very little turnover there in the last 10 years, and to grow academic careers as well as clinical careers that I think has helped both of those rise together in Uganda. And then it's local advocacy. Dr. Akello at the Uganda Heart Institute and his collaborators are at the ministry monthly giving reports. They collect good data, so they're able to show the ministry the data on the burden and the need and the impact of the interventions. And it's really bringing the ministry on as true partners and collaborators with the clinicians that have allowed them to make sort of slow steps over time that now have led to this larger implementation project, which to the ministry in Uganda and to our team seemed like a very logical next step because it built on 10 years of research and advocacy and data that we were showing that this was the next thing that we could do together. While Uganda is special to me and special in its place in the rheumatic heart disease world, I think what we've also seen is sometimes these initiatives feel overwhelming. If you say, like, let's take echo machines and put them in all the primary care centers and let's teach all these people to screen, it seems like something that might just be too big to start with. But I think these examples of it wasn't that hard. We did it. It went way better than we thought it would go, quite honestly. The adoption rate, the enthusiasm by the primary care nurses, the pride that we see when they find a case and that case comes back to them on prophylaxis now to care for, and they see better outcomes, and the community support that we're seeing from the general community about this program being in their place where they live has been enormous. And I think that's an example that we can use now to advocate at other places to say, this is what it took, this is how it's working. These are the challenges. They are real challenges that we're constantly pivoting and trying new things, but that it's possible, and here's a package you can start from, I think will go a long way.
Thank you. You mentioned something about staff retention. And I'm thinking about my country. We are losing specialists. Doctors are flying out of the country by the minute, by the hour. And I'm wondering if I have this kind of program, how would I sustain it? With everybody leaving?
Yeah, I think there's tricky parts on staff retention from the primary care system all the way through the tertiary system. At the primary healthcare system, we have had challenges because there's a system of staff rotation in the primary care system that we didn't know about when we started this program. And so it's really forced us to think about leaner models for continuing education and how do you have a model that can continuously retrain staff to take up these jobs when they're being shifted between centers on an annual basis. That was a big challenge of our program the first year. We've done that through shifting some of this to more technology-based learning, using modules that get pushed out to smartphones that our staff has that focus on pattern recognition and how do you interpret echoes, so there's not as much in-person training. A lot of that work is just now being evaluated as we're pivoting to a model that's less human-to-human training. At the Heart Institute, we've had a lot of discussions there around how they've retained their staff so well. It certainly isn't financial compensation. I know what they're making at the Uganda Heart Institute, and that is not the driver of why people are staying. When you talk to the faculty there, when you talk to the director, Dr. Omagino, and to the folks who run those divisions, they really express that it's the ability to practice medicine closer to where they were taught to practice. And that comes with expanded capacity, and KK has built some of this capacity at the Uganda Heart Institute, expanded skills capacity and expanded infrastructure to be able to deliver the care they know how to deliver, reduces frustration, and then to be able to grow these academic careers next to that. And I guess the other thing would be their intentional focus on training that they took on about 10 years ago to continuously build new fellows and new faculty has really expanded their capacity enormously.
Yeah, thank you. KK, you want to add something?
I say that one key element to staff retention is getting all the stakeholders to have a sense of ownership in the whole agenda. And if you can get that, then they sense a sense of pride. And I absolutely agree with you. It's not money that retains people. Yeah. It's a sense of belonging.
Sure.
And when they feel alienated, that's when they leave.
Yeah. Right. Thank you. So I think we'll pause here because one of our panelists just joined us. He left a meeting to come here, and that's Dr. Anshu Banerjee, from the World Health Organization, Department of Maternal, Newborn, Child and Adolescent Health and Aging. His public health leadership spans over 3 decades and supports integrated approaches to child and adolescent health, including advocacy for strengthened antenatal care and early intervention to reduce the burden of congenital and rheumatic heart diseases. So he's going to give us his talk, and then we'll take questions from the audience, and then we'll continue the discussion. Thank you, please.
Thank you very much, and sorry that I couldn't attend the rest of the meeting, but we are in a board meeting and had to just come here. And so I was asked to say a little bit about WHO, and maybe just to say that, and I'm sure that these figures have already been shared earlier today, but that from congenital heart disease perspective, it's around 45% of overall mortality due to congenital diseases in children under 5. While it's actually only 14% of the prevalence. And when it comes to rheumatic heart disease, 55 million people who are living with rheumatic heart disease and 360,000 deaths a year. So big burden, and therefore for us as a department, an area to address. So what have we as WHO been doing? Well, of course, we've been working with partners, very much with World Health Federation, with REACH, etc. But linking it up maybe, first of all, for congenital heart diseases, at the moment, first, last year we had a resolution to reduce maternal and child mortality, and within that we really specified the need for countries to start setting up programs for screening, diagnosis and management of birth defects. And so that led then to us and we have a strategic technical advisory group of experts to our department, and as well around maternal, newborn, child, adolescent health and nutrition as well. And they asked us to develop a framework to look at prevention, diagnosis, treatment and management of congenital heart diseases. So we've had quite a series of consultations over the last year looking into that. We've just kicked off the component of the prevention, while we worked, let's say, over the last year around screening, diagnosis and treatment. And hopefully by November this year, we'll have that and present it back to our strategic advisory group and get that endorsed. What we did there was really leaving it very open to sort of say countries need to decide which congenital disease they would like to focus on, depending on their own epidemiology, burden, etc., their own programs. Some countries have started with metabolic screening, others have started with maybe more structural birth defect screening, etc. And so, the framework should be flexible enough for countries to sort of identify what they think their priority would be and how they can continue to build on what they have already in place in order to improve newborn screening and diagnosis and treatment. So that's on the congenital side, let's say. On the rheumatic heart disease side, we had a resolution 7 years ago, spearheaded by Australia and New Zealand. It didn't get a lot of financial support, unfortunately, even though we've tried very hard to do so. But I do think it led to us to develop guidelines on prevention and diagnosis of rheumatic heart disease, within which there is a recommendation around antenatal care, particularly looking at, well, you mentioned it, ultrasound screening and how to integrate that within antenatal care. We, of course, recommend that there is ultrasound screening for the child during antenatal care, but it would be good if that can be combined then as well, and make sure that, for those women, because in most cases it's undetected and it will appear later during the pregnancy when they deliver, often as a complication, and so to also screen pregnant women to see whether they have potentially rheumatic heart disease. So that's on the rheumatic heart disease side. Also, we are looking at how to integrate this into our pocketbook for management of childhood diseases, so that it's also practical. Our guidelines are often very, philosophical, let's say, and how do countries then actually implement it. And so with our handbook or pocketbook for managing childhood diseases, that's also where it gets integrated and to make it practical for the clinician, bedside management, etc. Let me see whether I forgot a few things. Then on the vaccine side for rheumatic heart disease, always a big discussion. Is it cost effective? Is it not cost effective? What is the clinical pathway that will allow us to actually evaluate the impact of the vaccine, etc.? A lot of work has been done around that by partners. There are, I think, at the moment 8 preclinical vaccines that are, in the pipeline, or 8 in the pipeline that are at preclinical stage, let's say. For the moment, I think WHO is focused more on Group B strep rather than in Group A, but there is a roadmap that was developed in 2018 and is used, let's say, also as a guiding document also by partners to sort of move the agenda around development of a vaccine for Group A strep. And so I think, where were we in Dubai? Abu Dhabi a year or 2 years ago now. 2 years ago, I think. And there was, of course, a lot of discussion around this, and there is a working group around it that really looks at how to move this agenda forward. So hopefully, but I mean, my understanding from our immunization colleagues is that, that's still most likely 10 years down the line, etc. So the other thing, of course, then is the prevention and the whole issue about early diagnosis of strep throats and potentially impetigo, etc. And so that is, again, included in our guidelines for management of childhood illnesses. But then also the whole issue of prevention or secondary prevention of additional infections through prevention through benzathine penicillin G. So there's also a roadmap and a working group around that. Also because it links to prevention of congenital syphilis. And that is also a WHO goal, let's say. And so there's also work around that. But again, there are always hurdles in getting that agenda moving, particularly because China is the main country that just has the raw material for that. So as part of that work, of course, there have been recommendations to really look at, improving the knowledge about the epidemiology, the burden of disease, etc. At the moment, when it comes to congenital heart disease, that's a piece of work that we're doing, and hopefully at the end of the year, we'll have the new estimates out around congenital anomalies, and that will, of course, include the estimates on congenital heart anomalies. And so that's a piece of work that's going on at the moment as well. And we're looking at 2-3 different models and comparing the different models in order to have, let's say, as good an estimate as possible. And of course, I'm always asking people to share data if they have data around this in order to strengthen the estimates. Let me see whether I missed anything I wanted to highlight. And of course, also we have the NCD package that a number of countries are implementing, so the PEN and the PEN Plus. And within that, rheumatic heart disease is also highlighted, and a number of regions have taken that forward to really integrate that into their NCD program in diagnosis and management. So that is sort of an overview of what we're doing in WHO, let's say, around these areas. And thank you very much.
Thank you so much. I cannot miss an opportunity like that. My name is McNab, and I represent FHO Foundation. We are a patient network, an organization of patient organizations in familial hyperlipidemia, so genetic lipid disorders and CVD risk factors. And I was very much attracted by the title of today's presentation. And although the group of people I represent are very, very common, and we actually 1.4 billion around the world. So, you know, we cannot categorize ourselves as neglected as such. Mm-hmm. And yet, everything that has been said today was around early detection, prevention, screening, and really giving a human being a good start in life. And so over 26 years ago, WHO issued 2 reports on FH, familial hypercholesterolemia. It's been over a quarter of a century ago. Not much has moved. And so I'm taking this opportunity with you in the room to say, we have cost effectiveness, we have medication, we have policies, plans, and yet there seems to be something missing. And it's my official plea to you as a representative of WHO a quarter of a century later to say, what else can we do as a community to prevent onset of CVD early in childhood and in families so they can be fulfilled participants in society? Thank you.
Thanks. So I can put you in touch with Kate, who is...
I would love that.
Who is, let's say, looking at the estimates, yeah? Because I'm not sure to which extent that is really coming out of those congenital disease estimates, etc. And if you have good data, you know, she can put that into the model, etc. So that's the first thing. Secondly, 3 years ago, I think, when we had a conference on rheumatic heart disease, on congenital anomalies in Chile, we put a coalition together. And so the problem with congenital heart disease is it causes, congenital disease or anomalies causes around 10% of under 5 mortality. But if you look at individual congenital anomalies, then it sort of disappears, yeah, because it becomes 0.2%, this one is 0.2%, that one is 0.3%, etc. And so what we really said is that as a community we need to get together. And so we will have at the World Health Assembly Monday morning, so coming Monday morning, at the John Knox Center, an event with this group around congenital diseases or anomalies, and many partners will be there, etc. So I'm not sure whether you're still here on Monday. But it might be nice for you to join that session and make the same plea. Yeah, be in touch.
For not clarifying, and I probably should have been a little bit more careful by saying that I'm talking about lipids, genetic conditions. So
yes, so it's congenital. No, I mean it's genetic.
Yeah,
it's yeah. That's how I took it. So I think it's important because, you know, we have people who advocate for cleft palate and cleft lips. Then we have another group for club feet. We have another group for congenital heart diseases. We have another group, yeah. So it's a coalition. Everyone is focusing on something else, but it's all congenital. And so my
I would love to take you up on the offer.
Yeah.
Yes. Thank you.
Okay.
Hi, Jeremiah Mwangi from the World Heart Federation. You talked a bit about the issue of translation from guidelines into action. And I mean, your department, MCH, I guess, I would imagine has got some success stories from where it's been effective in that you've had a guideline and it's translated into meaningful implementation of interventions and seen an impact on health outcomes. So I was just wondering from your own reflection on why we've struggled so much in RHD, and even with the guideline that we have now, what's missing? Is it money? Is it technical capacity? Is it something that a tool or resource that, you know, builds the gap between, just so we can think about as a next phase, we have the guideline, how do we move on from that?
Yeah, no, thanks. So indeed, I mean, it's a bit of all, yeah, it's both capacity and money, of course, translates potentially into capacity by having someone focusing on that area of work, etc. in WHO. So again, there on the guidelines, we were able to only address prevention and diagnosis. We were not able to go into management. which was, again seen as a big piece of work for which we didn't have any resources at all. So I think that would be an important addition. Yeah, and so how do we take that potentially forward? But it's also about supporting it at regional and country level, no? Particularly, we just heard examples of Uganda and how that's being taken forward, etc. But there's still going to be a huge burden. And so how do we support that country capacity, and how do we enable within a health system to take this agenda forward? Because in the end, is it going to be reimbursed under a UHC or a universal health coverage insurance scheme at the country level, or will parents have to pay out of pocket? So these are important questions that fit within overall systems thinking, and what is the capacity at country level to move that forward? So again, there, when it comes to congenital anomalies, we didn't want to have a fixed approach for countries, but really, say countries should decide on what they're already doing, and how do they take it on, and how do they integrate that into their either reimbursement mechanisms through universal health coverage insurance schemes, or if it's free care, how to ensure that's really free. There are always, hidden costs, etc., for parents. So those are some of the discussions, I think, that need to be had at systems level, health systems level. And so, yeah, it's, and you need to build that capacity at country level. No, you need to have the advocates at country level that understand how to have those discussions with the ministry at country level, etc.
So, Anna, please, can you go on with your question? So, Anna, the floor is yours. Can you unmute yourself and speak?
Thank you very much. I wanted to use this opportunity of us having also our colleague from WHO. I think that we should also use this time to reflect on care, diagnosis and management. We did not talk about it, but I'm really very happy to have heard my fellow panelists talking about patient engagement, increasing patient literacy to turn patients into partners. I liked the description from Dr. Beaton on how making efforts to incorporate difficult things can work. And I think that one area that we missed during our discussion was management of rheumatic heart disease, which I think is part of the full package of care. And I understand that we don't have a lot of evidence yet. However, there is some. There are a lot of us here on the panel also working on bringing such knowledge to the public. And I think that the PEN Plus strategy, by incorporating purposefully rheumatic heart disease, is in fact one of the many pathways to really reinforce the need for care, for research into care. There's a lot that is not known, although we say that it's just neglect on diagnosis. There is a lot of neglect also on management. And I think that we should take this opportunity to do that, to reflect on how we can foster more research and high quality research using the capacity of having countries such as Uganda, Mozambique, India into the network of countries that are implementing PEN Plus, and thus diagnosing and treating patients with rheumatic heart disease. Thank you.
Thank you.
Thank you.
Okay, so I think we can take a few questions from participants in the room for the panelists. And
there's some comment being typed by David, so we can probably check on whether there is. Can you just display the comments?
The comment from David.
David, you can say it out. Yeah.
Oh, yeah. I was just going to comment on what Jeremiah said, or the question about how we learn from the success of maternal and child health to date. And I think the big challenge is that a lot of the success we've had has been from interventions delivered through vertical programs. And while that's very impressive and something to celebrate, it works in countries without well-functioning health systems. And so, and if you look actually at trends in under 5 mortality versus neonatal mortality, we've seen a lot less progress on neonatal mortality because those interventions typically require a health system, whereas you can vaccinate kids who are over 1 very easily, and so on and so forth, nutrition programs. And so if we want to make progress on structural heart disease and childhood heart disease, I think we have to really, really push this health system development agenda, but be mindful of the fact that many countries where these conditions are especially endemic are not well set up to just deploy very complex interventions easily. And so I think some of the experimentation in Uganda that Andrea was talking about is very important. I think we need similar efforts in congenital heart disease to figure out how to develop lean models of surgical care and perioperative care that can be deployed in countries where continuity of care and coordination of care across levels of the system are just not the norm. And so I think that's the real innovation area here, the need for innovation. And I would hope that any future resolution would mention this need for developing this sort of coordinated care across the system to be able to do this sort of complex care that inevitably requires surgery, requires perioperative care, tertiary care, but it also requires integration with primary care, sharing of records and whatnot. So that was the spirit of my comment. Thanks.
Thank you. Do we have any questions from any other person in the hall? So while we're waiting for the questions, I have a question for you. In my country, the pediatric cardiologists had done, some work on congenital heart disease in under 5s. And what we found was that there was a lot of disparity depending on the region where you live. The people who live in the oil-producing areas, the prevalence rate was like double that of people who lived outside that area. And they were seeing the very complex congenital heart diseases, and we think it's because of the pollution from the gas flaring, the water is polluted, the ground is polluted. But the government is turning a blind eye. Nobody's saying anything.
Yes, thank you. We actually had that conversation with Dr. Finney on Saturday, the cardiologist, and she was also raising her concern because she was saying that in the northeastern part of Namibia, on the Kavango region side, there is an extreme high prevalence of congenital heart disease. And she was like, there needs to be a lot of, because Namibia is such a vast country, so even our regions are so different. So there's different, like you're saying, oil or what, but with us it's not the oil, but it's also just the climatic conditions that are so different. So I think, like you're saying, it is the government or the stakeholders do not necessarily pay attention to the high numbers. And for Namibia, for a country like Namibia, where you have 3 million, it is quite alarming. So I think that a lot of research needs, in our case, a lot of research needs to go into finding the problem and trying to see what it is that alleviates these numbers. But we can also only do this with the right partnerships. Because, we are not so advanced in research. So with the right partnerships and also the right advocacy, we can probably get to the root of these problems. Because I think if you go to the foundation of the problem, you might try and alleviate some of this problem so that the numbers are not that high. So I agree with you. It is, in our country, definitely a problem. And we are also hopeful that now that we have a new generation of lawmakers, that it will change. That these are now younger lawmakers, that they are more involved, that they are more educated, and that they also work closer with the communities to get to the root of the problem, and that we can only be hopeful to see a positive change And then I think it's also very important to have those passionate medical practitioners that are constantly advocating and also bringing it to the attention of the Ministry of Health where the shortages or the cracks are, and to make the right budget provisions to address some of these problems. Because sometimes we have the budgets, but it does not necessarily trickle down to the right departments.
So I think the pediatric cardiologists are pushing, but the country resource comes from oil. So they're looking at the resources and they're looking at the numbers we're presenting to them, and it's like they've made a choice. We'll just continue as usual.
Yeah, like I was saying, for us, it's not for us. We also recently discovered oil, but we have not seen the impacts yet because it's still an infancy level. But for us, definitely climatic conditions, because we have very harsh climatic conditions in Namibia, and like I said, the country is so vast that also people don't always have access to the right medical treatment. Because imagine if you have to travel 1,000 or 700 or 1,700 kilometers even just to get to the capital city where the hospitals and the resources are available. Sometimes patients don't even make the journey to get the proper treatment. So we also really need to look, in our case, we need to look at decentralization. But we can also only do that if we have the human capital. And that is something that we, as a country, unfortunately, we are failing in. We do not have the human capital, and that is why, for us, it's very important. Like I said, unfortunately for us also, because of our high upper middle income status, we do not necessarily get the partnerships and the aid that least developed countries or lower income countries are getting. So we need to create those partnerships that can be attainable to us, and especially on capacity building and getting to the level of specialists, that we have our own specialists and not necessarily need to rely on South Africa to refer our patients to South Africa to get the assistance that they need.
Okay, so I don't think we have any questions from the audience. So 30 seconds, what do you want us to take away? What is your message? 30 seconds for everyone on the panel. I'm starting with you, KK.
It's hard to answer this incredibly complex and encapsulated in 30 seconds, but I think the one area that I'm really concerned about is the disconnect between those who are in the field as to what the actual priorities are. That disconnect between the healthcare professionals and societal priorities is widening. So I'm just giving an example. In my area, pediatric cardiologists want to all do interventions and close small heart defects. It's just not a priority. What we need is development of surgical programs. So we need a much more conscious group of, much more enlightened group of medical professionals today. They can drive the agenda more effectively. That's one. The second is definitely the importance of integrating the patient's experience and the patient voices into the whole process. We're doing very poorly on that. We just have to do it much more aggressively.
Okay. Tanya?
I agree with everything that you said. And just the importance of collaboration with multi-stakeholders, I think, is the only way to move forward with this.
Thank you. Andrea?
I'll say that to me, the biggest gap here is that translation of knowledge to practice. And we can do better, and we have a lot of knowledge. We certainly don't have it all, and we should continue research onto new strategies, but getting what we know works out to populations just has to be a global priority and should be a big focus of the resolution.
Thank you. Anna, your last words for us, 30 seconds.
For me, it would be addressing fragmentation of care, talking outside the cardiovascular community. We need to go multi-sectoral with these conditions. We need to see children and those who are affected by these conditions as a whole, and we need to incorporate these aspects, these medical aspects, into the full range of social and economic determinants of health. Thank you. David, the last words for us.
I would just highlight the importance of the human capital and workforce in all this. If you're a policymaker who wants to do something on cardiac surgery next year, you should have started 15 years ago. It takes a long time to train surgeons, and without advanced planning and starting small and developing regional training programs, you're not going to get anywhere. So thinking about regional coordination and building that capacity, building on great networks like Children's Heart Link, I think will be a really important priority for getting countries started.
Thank you. And I would like to invite Jeremiah to close the session. Thank you so much.
Thank you, Amam, and thank you to all our panelists. My role in this is really just to talk about what WHF is going to do next and to share just a few thoughts and reflections on what we heard today. So, of course, we have the Neglected Cardiac Disease Expert Group, which is chaired by KK, and this group helps set the agenda for the priorities that we will be working on, and they will direct us as we go forward. But it's important to remember that WHF is a membership organization, and our agenda is set by the members. And so if this is a topic that requires more work on our part, that's really important that our members say that to us and say that we are prioritizing these issues. WHF is an awareness-raising organization, it's a policy translation organization, it's an advocacy organization, and cardiovascular disease is a broad area. But I think there are so many opportunities that we heard about today from the panelists and from Anshu at WHO in terms of taking this another step forward. I have a personal bias. I worked a lot on the RHD resolution in 2018, and it's true, 7 years on, it's quite disappointing to see where we are, and we know that COVID was a big barrier to that. And in fact, the report was meant to be in 2021, but I think it was actually in 2022. And the final outcome of that report was to put RHD in the Global Strategy on Maternal, Child and Adolescent Health, and so now it just gets a line rather than an agenda item. So I think that there's a lot of lessons to be learned from that, but I think the strength of WHF's members, and Anshu talked about the in-country work. What can we do in-country to persuade whether we're a country that has resources and finances and funding, or a country that requires technical assistance? How do we encourage the policymakers in those countries to either contribute more and support the programs? Because we talk a lot about having cost-effective interventions, but they require, in many cases, a heavy upfront investment that just isn't there. We've been doing a series of roundtables in low-income countries, and every time we talk about, where's the financing and how are you prioritizing what you work on, the majority of the money goes to staff costs, and any program is typically funded by a donor. So to have a step forward, we need either donors, or we need to be very creative with how we can train health workers who are then already built into the cost, but still there's an investment there. So I think thinking about how we strategize on this topic, and we've talked about more broadly childhood onset, and where we invest our time and resources, I think there's a lot that we can do together to really start to put a bit more pressure at the national level, at WHO and others. So I just want to say thank you for all your contributions. Clearly, this is a topic when we look at it from an equity lens, from a humanitarian lens, that we should be tackling. So I look forward to working with everyone as we go forward. Thank you.
Thank you.